intracranial hemorrhage. So you have to consider both of these things before you write down an answer. So the most likely, so what is the best answer here? Now this is a patient who presents with a STEMI. There is evidence of impending cardiogenic shock LVF story. And there is a history of ICH in the past. Right. So purely because of the ICH history, right, thrombolysis is contraindicated, right? And if the patient has an ICH at any time, that would be a contraindication for thrombolysis. Even if you forget that point, it is clearly proven that high-risk patients with STEMIs, especially people who have heart failure, who have cardiogenic shock, right, who had arrhythmias during their presentation, they do better with PCI, right? They do better with PCI. So all efforts should be made to arrange a PCI for these people, right? So patients who are high risk, patients who have cardiogenic shock, patients who have LVF, patients who have developed arrhythmias during the course of their STEMI. So these are people who have a better outcome with PCI, right? So because of those two reasons, I would say that PCI is preferred, right? And of course, we do PCI when there is a contraindication to thrombolysis, like an ICH, for example, right? And also atypical presentations. Right. Okay. Any questions about that one? No? Okay. Right. Now the next question is a patient who has an inferior STEMI. The key thing here is the patient is hypotensive and bradycardic. Now we talked about this the last day, we discussed MCQs, and I told you that there is a very important point about a patient with an inferior infarction because the culprit artery here is the right coronary artery. I also told you that the right coronary artery supplies the conduction pathway. So it's a very high incidence of bradycardias and heart block, right? That is a very common complication of patients with inferior STEMI. Now, in addition, Lamai, this patient is hypotensive. Why is the patient hypotensive? The patient is hypotensive in this situation because of a right ventricular infarction. And that again, right coronary artery, common supply, inferior, right, it's a common story going on. So this patient has a right ventricular infarction, right? Now let me show you this next picture to explain what goes on. Right. Now, when there is a right ventricular infarction, Lamai, what happens is, as shown on the picture here, the right ventricle dilates. Right? When there's a right ventricular infarction, there's acute dilatation of the right ventricle. What that does is, as you can see, is it sort of pushes the ventricular septum onto the other sides, because as with the right ventricular region dilates, there is volume overload of the right ventricle, and that pushes the septum to the other side, right? And that compromises the left ventricle, as you can see, right? That compromises the left ventricle. Right? And that causes a drop in the blood pressure because the left ventricle is now compromised. Right? So this is what happens in a right ventricular infarct, right? Acute right ventricular infarct. Now, there are two ways of treating this condition. The first thing we do, what we do is, and this might sound a little bit funny, but let me explain that. We give fluid. The first thing that we do for a right ventricular infarction when the patient is hypotensive is we give fluid. The intention of that is to drive fluid through, push fluid through the right ventricle into the left. So we are trying to force fluid in, right, through the right ventricle into the left side. So we are forcing fluid through. So we get a fluid bolus at pressure so that you cover that filling, right? So increase the left ventricular filling by pushing fluid through. right? So the start of the treatment is with fluid boluses, right? That is the first thing that we do, right? And then you add on inotropes after that. So fluid boluses and inotropes together would be the treatment, right? In this patient. The next step is fluid, right? That's the first thing you do. Right. So the idea is trying to push fluid through the right ventricle into the left heart at pressure. So you give a good fluid bolus, say 500 ml to 1 liter of fluid. Right. So that is that. Right. So what you do is you push fluids through and then you add on an inotrope, right? And the inotrope obviously increases the contractility of both ventricles, right? And also it has certain effects on the pulmonary vascular resistance as well, right? Which reduces the strain on the right ventricle. So the combination therapy, you start off the fluid, then start them on dobutamine, which is the commonly used inotropic agent. So that is how you manage it, right? So it's very important. So in an inferior STEMI, you get conduction blocks and right ventricular infarcts as common complications, and they then present with bradycardia and hypotension because of this. Right. Okay. Right. Now, this question on hypertension focuses on a patient with young hypertension. Now, if you remember the classes that we did during the professorial appointments, and if you follow those classes properly, you can answer a whole load of your MCQs, no problem. So remember we talked about young hypertension, and I told you that if you have a patient with young hypertension, there is a very high possibility that it is due to a secondary cause. So in a patient with young hypertension, it is likely that this is due to a secondary cause. And this whole question is trying to sort of match up clinical manifestations with secondary causes, right? And in the next slide, I've shared all these slides with you. I've just given you a revision of what we did during the long case discussions. So the cause for secondary hypertension, the clues in the clinical diagnosis and investigations. During your prof appointments. Right, so let's try to go through this now. Absent femoral pulses, that is an indication of coarctation of the aorta in this setting. In addition to absent femoral pulses, they can have a radiofemoral delay or a radioradial delay, depending on where the coarctation is. So that's true. Conn syndrome, remember that? So Conn syndrome is where there is an aldosterone secreting tube in the adrenal gland. And all of you know that aldosterone, what does it do? Aldosterone, it pushes out potassium, secretes potassium, giving rise to a hypokalemia. Another thing that it does, it pushes out hydrogen ion, giving rise to a metabolic alkalosis. So Conn syndrome, the typical metabolic picture, we do this in endocrinology also, the typical metabolic picture is hypokalemia with metabolic alkalosis, right? So that is important. So Conn syndrome, hypokalemia is correctly matched. Pheochromocytoma with cafe au lait patches and neurofibromata is a slightly difficult thing, but if you know that, that's good. Remember, pheochromocytomas are associated with neurofibromatosis. So there is a strong association. In neurofibromatosis, people get pheochromocytomas. That is true. Right. In renal, we will talk about IgA nephropathy. IgA nephropathy typically presents is a glomerulonephritis, can cause hypertension. It presents with nephritic syndrome and hypertension. And hematuria is a classical presentation of IgA nephropathy. So that is true. Cushing syndrome again is an excess of glucocorticoids. Remember, there is a classical phenotypic presentation in Cushing syndrome, which we'll do a lot of when we do the endocrine MCQs. Because of the glucocorticoid excess, apart from the classical moon phase, striae in the skin, proximal myopathy is very common as well. Proximal myopathy, because of the steroid effect, proximal myopathy. Right. So All of these are right, correct. Yeah. Any questions?
Excuse me, sir.
Oh, can.
The Cone syndrome එකේදී තියෙනවද proximal muscle paralysis එක?
Proximal muscle paralysis එක එන්න පුළුවන් because if there is very severe hypokalemia, you can get muscle weakness even in Cone syndrome. I thought I told you that. නේ ඒ දවස්වල මම කියනවා මතකයි. Yeah.
Thank you, sir.
Right. Good. Right. Now, just a quick summary about the treatment of hypertension. Again, we did this during your long case discussions. This is just a summary. You can have a look at this, but essentially remember the decision to start antihypertensives depend on several things, right? Chamatkar, come back to the question that you asked. Just give me a second, right? So hypertension, the decisions to start antihypertensive therapy are based on several things. Number one, the grade of hypertension. How high the blood pressure is, number one. Number two, the presence of end organ damage. The presence of end organ damage, right? Presence of end organ damage. Number three, the third factor is the cardiovascular risk. What is the extent of the cardiovascular risk that the patient has? So these are the three most important factors. Number one, how high the blood pressure is. Number two, what is the burden of end organ damage, right? What is the amount of end organ damage that the patient has? And the third factor is the cardiovascular risk assessment, right? So this will determine whether you start antihypertensives. These are the factors determining whether you start antihypertensives. Of course, you need to take patient choice into account as well, right? So that is also a factor. But the most important factors are number 1, 2, and 3. Right. Now, again, in the prof appointment, I told you about the treatment algorithm for hypertension. And currently, I think the most reasonable, closest guideline to Sri Lanka is the NICE guideline, right? And we've been using this for a long time, or similar guidelines for a long time, right? According to the NICE guidelines, the first-line drugs are ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. Those are the three first-line drugs. Diuretics have sort of been demoted or pushed down into the second level, as you can see in this picture. Right? Second level. Right, now let's look at this MCQ. True or false regarding the management of hypertension? Thiazides are contraindicated in the elderly. Whereas that's wrong, right? Thiazides are not contraindicated in the elderly. Thiazides are no longer first-line antihypertensives. That is what I told you just now. But they are good antihypertensives, right? And we do use them in elderly people. That is not a problem. We do use them in elderly people. So it is not contraindicated. Remember, this is very important. Make a MCQ that thiazides can cause electrolyte imbalances, right? So to be very careful when you're using your thiazides, right? Especially hyponatremia is something that you get. Tisura.
Sir, thiazides are cautioned in the elderly.
Cautioned but definitely not contraindicated, right? Definitely not contraindicated. Elderly hyponatremia can be troublesome, so you're a bit cautious, but they're not contraindicated. Yeah.
Right. Thank you.
Okay. Right. Second MCQ. ACE inhibitors are contraindicated in patients with concomitant diabetic nephropathy is absolutely wrong. And of course, if you look at the NICE recommendations, in fact, if the patient has diabetes, this is preferred ACE inhibitors or angiotensin receptor blockers. So what is the basis of this recommendation? ACE inhibitors also reduce proteinuria. Apart from its antihypertensive effect, it reduces proteinuria. And the reduction of proteinuria itself is good for you. It prevents the progression or limits the progression of diabetic nephropathy. So, because of that, but actually ACE inhibitors should be given if you have diabetic nephropathy. because they reduce the proteinuria, reduce the progression of diabetic nephropathy as well. But of course, and this is a common question that you ask, and I'm sure you asked this during the prof appointment as well. When the patient gets closer to end-stage renal failure, you have to be careful with ACE inhibitors purely because they cause hyperkalemia, right? So you have to be careful if they are in end-stage or close to end-stage renal failure because they can cause hyperkalemia. So be careful. You can be careful, right? Hi. Okay. Right. Now, with that, we go to calcium channel blockers are the preferred antihypertensive for use in pregnancy. In obstetrics and gynecology, I'm sure they still use methyl dopa. Is that right? Correct me if I'm wrong.
Yes, sir.
Yes. Okay. So, in pregnancy, methyl dopa is what is preferred, right? Calcium channel blockers can interfere with fetal, not fetal, another name, especially towards the last trimesters, can interfere with uterine contractions and things as well. So, methyl dopa is still what we commonly use in pregnancy as the first line antihypertensive. Hari. So, spironolactone is the drug of choice for patients with resistant hypertension. Now, again, talking a little bit about resistant hypertension. What is resistant hypertension? So, you're on at least 3 or more antihypertensives, and one of them is a diuretic. So, one of them has to be a diuretic, and that maximum tolerable doses. The word is important, tolerable doses, right? So, resistant hypertension can occur. When you have a patient with resistant hypertension, again, you have to screen them for a secondary cause. And we do recommend, there are 2 antihypertensives which are recommended in resistant hypertension. Spironolactone is considered to be the drug of choice, and there is evidence that it works. Alpha blockers are also used, but based on current guidelines and recommendations, spironolactone is the drug of choice. But remember, you have to also correct the underlying cause if you can find one, right? That is also important. But currently, based on current evidence, guidelines will say use spironolactone as the drug of choice, or if that does not work, alpha blockers. The last statement, again in your acute medicine classes, I told you about hypertensive emergencies and urgencies. Matakaini neda. Hypertensive emergency is where they present with hypertension, elevated blood pressure with acute end organ damage. And I gave you a slide which gives you the definition of the acute end organ. Okay, but it is in, I have given these slides to you, right? So acute end organ, what are the definitions of acute end organ damage? And I told you there very clearly that in patients with hypertensive emergencies, you have to give them an intravenous antihypertensive, right? Intravenous. Why? Right? Why? Because one, it works quicker. Intravenous antihypertensives work quicker. Their bioavailability is better. But actually, even more than that, you can control it very nicely. Ne? Because you are giving the intravenous antihypertensive through an infusion pump, you can control it very nicely. Right? Control karanna puluwan. Dose එක අඩු වැඩි කරන්න පුළුවන්. You can control the dose very effectively. So titrable. The dose is titrable. Because of all these reasons, you use intravenous antihypertensives, hypertensive emergencies. In hypertensive urgencies, just the high blood pressure. No acute end organ damage. There is no acute end organ damage. In that, you can manage it with oral medication. You don't need to use IV. So the statement is false because it says hypertensive urgency, right? But if it was emergency, it is true. You use intravenous hypertensives in emergencies because of the reasons I just mentioned. Rehani, beta blockers can also be used in resistant hypertension, but it's not a first-line choice. Spironolactone is a first-line choice, but alpha blocker, beta blocker can also be used. Yes. Hari. Okay. Any questions about that? Number 9. Right. Now this best response MCQ is a very interesting, slightly tricky one, but good question. So answer is yes, manage hybrid just with oral antihypertensives. There is no strict recommendation. You can drop the blood pressure over about up to 24 hours even. Slowly over 24 hours you can manage the blood pressure just with orals, right? So you don't need to do anything dramatic. And sometimes patient can be discharged also on maybe an increased dose of the usual oral drugs.
So that was my question. So can we manage them outpatient or
can, depending on the blood pressure level, of course. In Sri Lanka, we have a slightly sort of a low threshold for admission. Ne? පොඩ්ඩක් ප්‍රෙෂර් එක අපි ඇඩ්මිට් කරලා oral ටිකක් දීලා හවසට යවන ගතියක් තියෙනවනේ නේද? But and I think Sri Lanka is also moving towards this now. There is a trend now for something called ambulatory care. ඒ කියන්නේ දැන් this new building that they have built, I think will ultimately turn into something like that in NHSL, where there is a ward there, but just 24 hours. Ne? Outpatient management. පැය කීපයක් you observe and send the patient home directly. Right? So outpatient management. Right? There are services where nurses go to the home and check blood pressure also in some countries, but of course we don't have that in Sri Lanka. But we have a slightly admit karanawa goda. But you can manage them as outpatient. There is no major problem. Right. Now the key features in this best response MCQ are the patient is hypertensive. There is some vascular story, the intermittent claudication vascular story. And even more important here is the ultrasound shows different kidney sizes. What does that indicate, or what might that indicate? How does it impact on your choice? Does anyone know why the kidney sizes are important here? And the history of vascular history එකක් තියෙන එක. Yeah. So Rehani has suggested renal artery stenosis. Yes. So the possibility is that there is some atherosclerotic renal artery stenosis. Would have been a better answer, Rehani. Why am I saying atherosclerotic? Because of this intermittent claudication, there is some atherosclerotic burden going on. There is some atherosclerosis going on in other vascular territories. So again, as I have taught you, I am sure, we try to avoid ACE inhibitors and angiotensin receptor blockers in patients with renal artery stenosis. Especially if it's bilateral, but even in unilateral, if there are other drugs you can use, go ahead and use them, right? Because in renal artery stenosis, the renal perfusion is driven by angiotensin 2, right? The renal perfusion is driven by angiotensin 2. So you better not play around with that. So in this patient, a calcium channel blocker like amlodipine is a good choice. Amlodipine is okay because it doesn't interfere too much with the vessels, right? So it's mainly cardiac and blood pressure. So amlodipine is a good antihypertensive in this situation. Hi. Good. So we're sticking to this first line concept of calcium channel blocker or ACE inhibitor ARB. In this patient, you can't use a ACE inhibitor, right? Because of the possible renal artery stenosis. Right. Any questions? Right. SCQ එක මම කිව්වා වගේ පොඩ්ඩක් ඔයාලට උත්තර තියලා ලියා ගන්න. We will discuss a few after we finish the MCQs. හරි මම අද discuss කරන්නේ මේකේ උත්තරේ තියෙනවා. The structure of the answer is in those slides. Hi. Okay. Right. So let's move on to the next one. Hi. Can you see the slides here?